السلام عليكم.
عليكم السلام.
Good afternoon, everyone. So I would like to welcome you to our academic activity today. We have two interesting lectures today. First one about myocardial protection will be presented by Dr. Rowan Zamdi, and the other one is about deep hypothermic circulatory arrest by Dr. Rasha Maqis. So maybe we can start in 5 minutes. Rowan, you can prepare your slides if you don't mind.
السلام عليكم.
عليكم السلام.
Dr. Loy, I can start now.
Yes, Raman. First, I would like to introduce and welcome Dr. Nasser, who's a consultant of anesthesia from King Fahd Air Forces Hospital. Welcome, Dr. Nasser, and thank you for accepting our invitation.
Welcome, Dr. الله يبارك فيك. أهلا بك.
I believe we can start, Rohan. Thank you.
Assalamu alaikum. My name is Rana Ghamdi, cardiac surgery resident R1. Inshallah, today I'll be talking about myocardial protection. What are the different types of myocardial protection? I will talk about cardioplegia, its principles, the different solution types you can use, and the methods of delivery and strategies for delivery. So a successful outcome after cardiac surgery depends on many factors: accurate recognition of the pathology and the choice of method to achieve cardiac repair. Equally important are the physiologic consequences of the operation. Ventricular function must be preserved or improved during cardiac procedure. Myocardial protection is therefore the crucial component of success in cardiac surgery. It refers to strategies and methods used either to attenuate or to prevent post-ischemic myocardial dysfunction that occurs during and after heart surgery. The use of cardiopulmonary bypass and cross-clamping of the aorta deprives the coronary artery from oxygenated blood. During this ischemic time, damage to myocardium need to be minimized, hence the concept of myocardial protection. Goals of myocardial protection: it should minimize and protect against myocardial ischemia and damage during cardiopulmonary bypass by reducing myocardial O2 demand. It should provide emotionless, bloodless field and allows effective post-ischemic myocardial resuscitation. Several methods of myocardial protection can be used to reduce the O2 demand: putting the patient on cardiopulmonary bypass to unload the heart, the use of cardioplegia, and hypothermia. O2 demand are reduced by around 90% simply by arresting the heart at normothermia. So maintenance of arrest during the cross-clamp period is essential. In the table here, you can see the difference of O2 demand in the beating heart after putting the patient on cardiopulmonary bypass and after delivering of cardioplegia. You can see it's decreasing by around 90%. Cooling of the heart, it further reduces the myocardial oxygen consumption and metabolic rate by around 7% for every 1 degree decrease in the temperature. So as you can see, the reduction in myocardial metabolism attributed to hypothermia is actually quite insignificant compared with that achieved by cardioplegia. Affecting of cooling on the myocardium, it decreases the oxygen demand, decreases the metabolic rate, the ATP generation, and the membrane stability. It increases the calcium sequestration, the glucose utilization, and hyperviscosity. Ischemia reperfusion injury represent damage to tissue following restoration of blood supply after a period of ischemia. The reperfusion triggers an inflammatory response inducing tissue damage secondary to oxygen-free radicals, calcium influx, leukocyte, and lactate accumulation. The oxygen-free radical induce damage to the tissue by inducing interstitial and intracellular edema and endothelial injury. It manifests by low cardiac output and hypotension, and it may result in cardiac arrhythmia and myocardial cell death. So several methods of myocardial protection can be used to reduce the O2 demand. Cardioplegia is the main stem, and we have a non-cardioplegic methods such as off-pump coronary artery bypass surgery, on-pump beating heart surgery, and hypothermic fibrillatory arrest. Cardioplegia is used to arrest the heart after application of an aortic cross clamp that interrupts the coronary circulation. Applying the aortic cross clamp without the use of cardioplegia result in anaerobic metabolism and depletion of the myocardial energy stores. So without a reduction in myocardial metabolism and auto demand, either by cardioplegia or hypothermia, ischemic arrest for more than 15 to 20 minutes would result in severe myocardial dysfunction. Off-pump coronary artery bypass surgery, it's performed without the use of cardiopulmonary bypass on a beating heart. Using off-pump coronary artery bypass removes the ischemic insult of the aortic cross clamp, the inflammatory response caused by hypothermia, ischemia, and the contact of the patient blood with the artificial surface of the cardiopulmonary circuit. Also, disruption of the coagulation system and hemodilation after cardiopulmonary bypass is avoided. It may reduce the complications of cardiopulmonary bypass, the risk of stroke, renal failure, and prolonged respiratory assistance. If ischemia develops as evidenced by ECG changes or ventricular dysfunction, intracoronary shunting or aortocoronary shunting can be used to provide distal flow until the anastomosis is completed. On-pump beating heart surgery can be performed without aortic cross clamping, allows for the construction of distal anastomosis on a beating heart while the pump provides systemic flow. This technique should be considered when safe aortic clamping cannot be performed, usually in calcified or severely atherosclerotic aorta. It can also be used for operations such as resection of a left ventricular aneurysm or surgical ventricular restoration, allowing the surgeon to palpate the border zone between the viable muscle and scar tissue better than if the heart was arrested. Hypothermic fibrillatory arrest, it's a variant of the empty beating heart approach. It can be used for coronary surgery with the heart in fibrillation and the aorta remains unclamped, and the distal anastomosis performed on a cold, vented, fibrillating heart. In this technique, we can avoid the air ejection during the procedure. Of course, the heart is defibrillated after the completion of the anastomosis. Now let's talk about cardioplegia. What are the different types of solutions? What are the different methods to deliver the cardioplegia and the routes for delivery? Promote diastolic arrest of the heart is achieved using a delivery of solution containing about 20 to 25 milli equivalent of potassium chloride. We have two types of plegia solution, crystalloid cardioplegia and blood cardioplegia. Temperature of cardioplegia solution can be called warm or in between. So what are the different methods for delivery of cardioplegia? Delnado consists of crystalloid component, which is mixed with blood in a ratio of 4:1. 4 parts of crystalloid to 1 part of fully oxygenated patient whole blood, usually obtained from the bypass circuit. It functions primarily by arresting the heart at cold temperature, usually giving cold at 4 to 10 degrees. The crystalloid component of Delnado contains a base solution of plasmalide, as you can see it here in the picture, which has an electrolyte composition of similar to the extracellular fluid. Added to plasmalide are mannitol, which has been shown to both scavenge free radical and reduce myocardial cell swelling. Magnesium sulfate for membrane stability, sodium bicarb as a buffering agent, potassium, of course, the main arresting agent, and lidocaine to prevent arrhythmia. The other component is blood. It has been shown to improve coronary perfusion during cardioplegia delivery. Furthermore, studies have shown that blood cardioplegia preserve myocardial metabolism and function and result in less metabolic ischemic stress and reperfusion injury. So for an example, 4:1 ratio, it means if we gave 1 liter of Delnado, we will give 800 ml of crystalloid and 200 ml of blood. This is 4:1 ratio. Blood cardioplegia, which can be given hypothermic or normothermic. Added to the blood is high potassium and magnesium sulfate. Clinical studies generally suggest that blood cardioplegia provides superior myocardial protection to crystalloid cardioplegia, with less troponin release and better hemodynamic performance post-pump. However, the rate of myocardial infarction has not been shown to differ. It provides sufficient cardiac nourishment during aortic clamping to permit excellent myocardial protection. So in compared to the crystalloid cardioplegia, blood cardioplegia provides oxygen and nutrient. It provides buffering capacity, minimize the intracellular edema due to its oncotic proteins, less hemodilation when large volume of cardioplegia is given. It offers a number of endogenous antioxidant and free radical scavenger, distribute cardioplegia more evenly, thereby inducing a faster onset of arrest. It's less complex than other solutions to prepare. Custodiol, which is histidine, tryptophan, ketoglutarate solution. This is an intracellular crystalloid cardioplegic solution. It is classified as an intracellular due to its low sodium and calcium content. Sodium depletion of the extracellular space causes a hyperpolarization of the myocyte plasma membrane, inducing cardiac arrest in diastole. This is different mechanism of action from the conventional extracellular cardioplegic solution, which are high in potassium content and cause arrest by membrane depolarization. This solution is administered as a single shot and is claimed to offer myocardial protection for about 2 to 3 hours, allowing the performance of complex procedure without interruption. It's mostly used in minimally invasive cardiac surgery or heart transplant. The component of custodiol, you can see it here in the table. A high histidine content buffers the acidosis caused by the accumulation of anaerobic metabolism during the long ischemic period. We have ketoglutarate, which improves the ATP production during reperfusion. Tryptophan, which stabilizes the cell membrane. Mannitol decreases the cellular edema and acts as a free radical scavenger. Terminal warm blood or hot shot. This is given before unclamping of the aorta and usually while performing proximal anastomosis or closing the heart. Warm blood, it's giving warm blood without potassium, which may restore energy and improve ventricular recovery, although data are very mixed. As well, it helps with de-airing. So the cardioplegia mixture passes through a separate heater or cooler system in the cardiopulmonary bypass circuit, with the infusion rate and the pressure controlled by the perfusionist. A low potassium solution is used to maintain the arrest while avoiding an excess potassium load. A high potassium solution should be re-administered if the heart resumes any activity. Failure to arrest can mean inadequate system venous drainage, incomplete aortic clamping, or aortic insufficiency. The route of delivery can be delivered antigrade, retrograde, or can be both antigrade and retrograde. Antigrade cardioplegia delivered via the aortic route proximal to the aortic cross clamp. The cannula contains a pressure line and a vent port to suction air and blood between infusions. Given at a pressure of 60 to 100, aortic pressure below 30 means that antigrade flow is insufficient. High aortic pressure, more than 100, may occur with extensive obstructive coronary disease. If this happens, the infusion rate should be slowed to give the correct dose over time. giving at a rate of 200 to 250 ml per minute, or it can be more in hypertrophied heart. The efficacy of antigrade cardioplegia delivery may be compromised by severe coronary artery stenosis and should not be used in moderate to severe aortic regurgitation. Why we can't use it? So we avoid the ventricular damage by mechanical dilatation. In this situation, an antigrade cardioplegia can be given, followed by direct ostial cardioplegia, or antigrade followed by retrograde cardioplegia through the coronary sinus. The placement of antigrade cannula. First of all, identify a favorable area on the aortic root, proximal to the cross clamp with adequate space for the aortic cross clamping. Check for plaques by palpation of the aorta, or evaluate with epiaortic ultrasound. Antigrade needle and cannula should be snared securely. Flush the cardioplegia line so that it is completely free of air. After cross-clamping, run your induction dose and inspect the root for evidence of dissection, and inspect the LV for distension. Retrograde cardioplegia, delivered via the coronary sinus. It is introduced to the right atrium through a small stab wound and directed to the coronary sinus. The retrograde cannula has a self-inflating or manually inflating balloon at the tip. It also contains a line for monitoring the infusion pressure. The pressure should be between 30 to 50. The coronary sinus can be injured by forceful cannulation or continued administration of cardioplegia. So careful monitoring of the coronary sinus pressure during administration of cardioplegia is essential. If it's too high, more than 50, coronary sinus rupture can occur. If it's too low, less than 20, there is usually a problem with the catheter malposition. It might indicate that the balloon is not inflated or not occluding the coronary sinus, or it might indicate that coronary sinus rupture has occurred. So if coronary sinus rupture happened when the pressure exceeds 50, the perfusionist might note a high pressure, then low pressure as a consequence of the acute perforation that happened. The placement of retrograde cannula. A purse-string suture is placed in the inferior lateral aspect of right atrium. A stab wound is made and retrograde cannula is placed and directed toward the orifice of the coronary sinus with guidance from the operator's opposite hand. The final placement is confirmed by palpation or transesophageal echo imaging, and further by distal pressure reading during the infusion. Some cannula have self-inflating balloon, as I mentioned, other must be inflated manually. Direct retrograde is a good way to ensure delivery down the right and left since the catheter is not advanced beyond the middle cardiac vein. Here you can see this is the antigrade, this is the cross clamp, and this is the antigrade cannula placed in the aortic root. This is the direct ostial, and this is the retrograde cannula introduced through the right atrium to the coronary sinus. Many variables influence the outcome and makes it very difficult to conclude which method of myocardial protection is truly superior in influencing the surgical result. The evaluation of the distribution of cardioplegic solution, the levels of cardiac enzymes such as troponin, the post-op hemodynamic performance, use of inotropes, the rate of a myocardial infarction and mortality rate. However, excellent myocardial protection can be obtained with strategies that adhere to the generally accepted principles of cardioplegia delivery. Most studies suggest that in low-risk cases, multi-dose cold crystalloid and cold or warm blood cardioplasia, whether giving antigrade or retrograde, or produce relatively comparable clinical result. In general, protection of the right ventricle is suboptimal with all strategies, especially in patients with right coronary artery disease. A combination of antigrade cardioplegia and retrograde cardioplegia, cold or warm blood cardioplegia seems to be best for high-risk patients and can be recommended for all operations. These are some general principles in myocardial protection and in delivery of cardioplegia. Use warm induction for severely ischemic heart. Induce cardioplegia arrest with about 500 ml of antigrade infusion, then complete it with administration of a retrograde or direct osteal. This is especially important, as I mentioned before, in patients with severe coronary artery disease or moderate to severe aortic regurgitation. If warm retrograde cardioplegia is used, it should be run as continuously as possible. A high potassium solution should be used if there is a return of cardiac activity. Administer 500 ml of hot shot just prior to removal of the cross clamp. Give this into the aortic root at a pressure that does not exceed 50 to 80 after ensuring that there is no air in the aortic root. During all phases, ventricular distension must be avoided to prevent the rise of ventricular oxygen produced by the increased wall tension. Careful adherence to the basic principles of cardioplegia, maintaining arrest and multi-dosing in particular, should allow surgeon to perform even the most complex time-consuming operations without worrying about poor myocardial protection. We'll go through clinical scenario and different situations, some of the difficulties that you might face and how to encounter them. This is just a summary of most of the things that I mentioned in the lecture. So you're doing an aortic valve replacement on a 65-year-old male patient with severe aortic stenosis, severe aortic stenosis and moderate aortic regurgitation with a history of previous CABG, LEMA to LID, and Seventh vein to PDA and OM. Discuss your options for myocardial protection. Again, minimizing the myocardial oxygen demand is the primary principle of cardioplegic arrest. This is best achieved by rapid diastolic arrest after the aortic cross clamp is applied. Potassium is the most electrolyte employed to produce a diastolic arrest, and there are several common additional components, including the sodium bicarb, the mannitol, the magnesium, and lidocaine, each with its specific reason why it's added. Options for myocardial protection for an arrested heart include antigrade or retrograde delivery, continuous or intermittent. Types of cardioplegia include crystalloid or blood-based solutions that can be warm or cold. At the end, there are several methods of blood and crystalloid cardioplegia solutions, but no evidence to support superiority, and preference tend to be surgeon or institution specific. This patient has important issues that influence the approach: a reoperation with prior LEMA conduit and the presence of moderate aortic insufficiency. Standard reoperative measures should be taken, including external pacing pads and prepped groins bilaterally in the event that emergency peripheral cannulation might be needed for bypass. In order to achieve adequate cardiac arrest with sufficient cardioprotection, three things in this scenario are important. Number one, excellent drainage through standard atrial, groin, or bicaval cannulation. Number 2, identify the Lima conduit prior to arresting the heart. The Lima should be clamped to prevent continuous perfusion during the aortic cross clamp. Number 3, retrograde and antigrade cardioplegia axis. Antigrade would perfuse the OM and PDA territories, but not the LAD. Retrograde would perfuse the LAD territory. And additional measures includes hypothermia. In the setting of the aortic insufficiency, a retrograde cardioplegia catheter should be inserted in order to ensure cardioplegia delivery. The downside of this approach is incomplete right heart protection when the tip of the retrograde cannula is distal to the middle cardiac vein. The other downside is that if you get a perforation of this coronary sinus during insertion, you are in a difficult situation as the posterior part of the heart is likely to be stuck from the prior operation. On the other hand, any dissection that you would do to facilitate retrograde insertion risk the damage to the graft. So do what you are most comfortable with, but demonstrate thoughtfulness in either direction. Okay, so after cross-clamping and delivering of 500 ml of antigrade cardioplegia, you note a poor distension of the aortic root, incomplete arrest, and left ventricular distension on the transesophageal echo. How would you proceed? You can switch to retrograde and turn on the aortic root vent. Another option is placing an LV vent in order to decompress the left heart, as cardioplegia crosses the incompetent aortic valve and fills the LV. However, it may be difficult to get the vent in during a redo. So you place an LV vent. The LV is decompressed, but electrical activity persists. As planned, you give a retrograde cardioplegia. You note persistent activity, and your perfusionist notes inadequate line pressure. You are unable to reliably palpate the retrograde catheter in the coronary sinus. Transesophageal echo suggests that the catheter is not in the coronary sinus. How would you proceed? Remember, this is a redo situation. You can open the aorta if you haven't already, and deliver additional antigrade cardioplegia directly down the vein graft to get the best arrest that you can, and call to moderate hypothermia. How do you ensure adequacy of the retrograde cardioplegia delivery? Look for the cessation of electrical and myocardial activity by checking the ECG and looking at the heart. Confirm with the perfusion team that you have adequate line pressure and flow. Observe flow through the coronary vein and arteries during retrograde cardioplegia. Check the right coronary sinus and left coronary sinus ostia after the aorta is open and retrograde is running to ensure adequate distribution of the retrograde to the right and left circulations. Most retrograde cannula tips have pressure monitor probe that report the pressure in the coronary sinus. An upper limit of the appropriate pressure is approximately 40. The myocardial temperature can also be a guide to the adequacy of the cardioplegia delivery. You should note decreasing in the myocardial temperature assist either manually by touching the heart or with direct temperature probe. After placing the retrograde catheter, you encounter some dark blood emerging from behind the heart. You check and notice a perforation of the coronary sinus. What will you do? The rigid catheter, as I mentioned before, can perforate the coronary sinus, especially in older and frail patients. If this happens, initiate the cardiopulmonary bypass, cross-clamp and arrest with antigrade cardioplegia, and repair the perforation directly with Prolene suture or with a pericardial patch. Upon infusing antigrade cardioplegia, the perfusionist note high line pressure. What are your next step in the management? This raises the concern for a dissection. Stop your antigrade flow. Check for kinks or clamps obstructing the flow along the line. Ensure that the cardioplegia is flowing down the appropriate path to the aortic root. Make sure that the pressure monitoring line is connected correctly. With regard to a potential dissection, visualize the aortic root and look for distension, dislocation, or bruising around the cannula. Also, you can ask the anesthesia to visualize the ascending and descending aorta with transesophageal echo. In case of CABG, while sewing the distal anastomosis, you notice increased bleeding from the coronary arteriotomy. How do you proceed? The concern is that the arrested myocardium is getting perfused. First, check that the aortic crest clamp is occlusive and the aortic root vent is on. Possible explanation for mild bleeding at the arteriotomy site is the presence of collateral circulation. If unable to identify a correctable cause, monitor for signs of electrical activity and consider cold topical saline and cooling the patient or more frequent administration of cardioplegia solutions. Finally, there are a few things to consider when thinking about persistent activity, which can be grouped under access, collateral flow, and myocardial mass. Access are your retrograde and antigrade cannula in place and properly connected. Is the retrograde too far and not protecting the RV despite antigrade? Collateral flow, is the cross clamp completely occlusive? Is the right side drainage adequate, or do you need an additional cannula? Is the left-sided drainage adequate? Is there so much collateral flow that you need an LV vent? Once drainage is optimized, do you need systemic moderate hypothermia to keep the residual collateral flow cold? Myocardial mass is the, if it's a heart so hypertrophied that myocardial delivery of cardioplegia is inadequate. So you should look for and ask yourself all these questions if the patient has a persistent cardiac activity despite a good cardioplegia delivery. These were my references. Thank you. Any questions?
Assalamu alaikum.
Alaikum salam.
First, thank you, Dr. Rawan, for this comprehensive lecture. I have only one question. What's the difference between the del nido and the blood cardioplegia?
Okay. The difference you mean in the delivery or?
I mean in a component. What makes them different? Because both are made of...
Okay, in the component, the del nido, as I mentioned, it consists of a crystalloid solution, which is plasma light with some additive and patient's blood. Okay, the blood cardioplegia consists of blood with high potassium and magnesium sulfate. Which one is superior? As I mentioned, there are some advantage and disadvantage for each, and there are not enough studies to mention that one method is superior to the other. The blood cardioplegia has advantage, also it has disadvantage. The same goes for the Delnado. And at the end, it's surgeon preference or an institution.
I agree with
So-
you, Rawan. Yes, it's Faisal. Yeah, I think surgeon preference or the center itself, and depend on the case also. Not all the cases, yeah, and we use the same. I think same cardioplegia.
I don't mean the effectiveness. I mean, what I cannot understand is the difference in components. Like the Delnido is not high in potassium. Then how does it arrest the heart? Is it
No,
by
it has a
low
potassium.
sodium?
It as you can see, this is the table that contains the additives. Potassium is one of the additives to the plasma light, so it has potassium. Potassium is the main agent for arresting. So it has potassium. It has some other additives, and it's giving with also blood. So 4:1 ratio. So as I mentioned, if we give 1 liter of the solution, we will give 800 ml of the crystalloid and 200 ml of blood.
Okay, thank you.
Thank you, Rawan. Anyone has any comment or question for Rawan?
لؤي,
Yes.
it's not يعني what Faisal was mentioning. It's regarding the potassium. What I understand that every cardioplegia has its own method of arresting the heart. It's not necessary the potassium, the high potassium. High potassium, okay, it arrests the heart, and so on, but different methods for different cardioplegia solutions. This is what I've read before. So it's not necessarily only the potassium.
Agree with you, Dr. Ayad, because custodiol, it's not a high potassium. It's an intracellular crystalloid, and it arrests the heart by polarization, and the Delnado with depolarization. So yeah, different mechanism.
Yes, I think this is what Faisal meant by this.
Do we have any of the seniors here around? Can you hear me?
Yes, doctor, we can hear
Yes.
Okay. Do you have any of the seniors here around? Mafi? Okay, but this is the answers that you're giving about the cardioplegia constitutions is not really perfect. It has more knowledge than this. I would advise you to read 2 or 3 reference articles on this. Thank you.
Okay,
Thank
you,
you,
Rawan.
everyone. Nice presentation.
Thank you.
We'll have 10 minutes break and then we'll start with the second lecture. دكتور رشا.
السلام عليكم.
عليكم السلام ورحمة الله. تفضل دكتور.
طيب أبدأ.
تفضلي.
Okay. Okay, hello everyone. My name is Rasha Bages. I'm R5 in Kafafa Hospital in Jeddah. Our next topic will be about deep hypothermic circulatory arrest and cerebral protection, which is the second part of the bypass. So the main objective we will talk about is the cerebral metabolism and the blood flow, pathogenesis of the brain injury during hypothermic circulatory arrest, deep hypothermic circulatory arrest and the main concept of it, pH management, safe duration of circ arrest, cerebral perfusion, pharmacological adjuvant, and the last topic is moderate hypothermia and complication of the circ arrest. Before before we go deep into circ arrest, we need to know what is the hypothermic circulatory arrest. Hypothermic circulatory arrest is mainly two parts, as simple as that. We stop the circulation totally in the blood while maintaining the cerebral protection, either by the hypothermia alone or by using selective antigrade cerebral protection or retrograde cerebral protection. So the main concept of the hypothermic circulatory arrest is two parts. It's to stop the blood circulation in the body and maintain the cerebral protection. Before we go deep into that, we need to know some basic concepts of the cerebral metabolism and blood flow. To know how to protect the brain, you need to know that the metabolic rate of and the energy requirement of the brain are approximately 7.5 times the metabolism of the non-nervous system. So it's a highly metabolic requirement organ. This means that the brain consumes almost about 60 milligrams of glucose and 3.5 milliliter of oxygen per 100 milligram of the brain. This translated to cerebral blood flow need about 750 to almost 1 liter blood flow per minute, which is almost about 15% of the resting cardiac output at the normothermic condition. So the requirement and the metabolic rate for the brain is very high comparing to the other organs in the body. The brain has an autoregulatory vasculature that usually autoregulate the cerebral flow in the brain while the patient in the normotensive condition, and the blood pressure between 60 to 140 mmHg, the autoregulatory of the brain is preserved. Also, the brain depends upon the aerobic process for energy, which is the main source of energy for the brain, and it's intolerant to ischemia. So, in the setting of the ischemia, it's quickly transferred to anaerobic metabolism. And once the energy source depleted, which is mainly the ATP, we will have
Rasha, we can't hear you.
sorry, there is some problem in the internet connection. Just give me a minute, please. Okay. Okay. So once the brain converts to anaerobic metabolism, lactate is reduced. احنا وصلنا هنا لا. Okay, so as we said, the brain depends upon the aerobic glycolysis, and once the ATP depleted, the potassium, the calcium will accumulate in the cells, and this will lead to irreversible neuronal injury. Once the brain converts to anaerobic metabolism, the lactate is produced, and the neuronal cells is unable to utilize lactate as an energy source. So this accumulation of lactate and combined with lack of blood flow during circ arrest will result in accumulation of lactate intracellular, and this will lead to a drop in the intracellular pH, and this will cause acidemia inside the cell. So the acidosis, intracellular acidosis effect on the cells will release potent excitatory neurotransmitter like glutamate and aspartate, and these two cause potent neurocellular damage to the brain. So to prevent that, we use hypothermia or systemic hypothermia to reduce the auto-consumption and the metabolism of the brain. So by reducing the core temperature of the body to 20 centigrade, this will reduce the auto-consumption to almost 76% of its baseline. And when we decrease it more to 15%, it will reduce the auto-consumption to almost 84 of the baseline, which means that the auto-consumption will be about 15% only from the baseline. Also, hypothermia will reduce the cerebral blood flow and cause cerebral vasoconstriction. And as we decrease the body temperature from the normothermia to about 22 centigrade, the cerebral microcirculation and autoregulatory of the brain will be lost and will be totally dependent upon the mean arterial blood pressure. This will give us a term called a luxury perfusion. Luxury perfusion of the brain, which give us a quicker, more homogeneous, perfusion of the brain, but it has also a potential differential effect, and it can cause a brain edema and expose the brain to microemboli. تاني قطع. ليش؟ عشان المطرة كل دقيقة بيقطع عندنا النت. So let's resume. So as we decrease the body temperature to 22, the cerebral microcirculation and autoregulation will lose its ability to regulate the blood flow. And this will give us a luxury perfusion of the brain, which give us a more quicker, more homogeneous cooling of the brain, which has also a potential detrimental effect in development of brain edema and exposure of the brain to the embolic fluid. The most clinically accessible method for cerebral for measurement of the or assessing the cerebral metabolism is the EEG. Silence usually indicate maximum cerebral metabolic suppression. So this table showing you the measurement of the cerebral oxygen metabolic rate and comparing it to the safe duration of the hypothermia. As you can see, in the normal temperature, the oxygen metabolic rate is almost 100%, and we can also keep the patient in hypothermia for 5 minutes. But as we go down with the temperature to 15 degrees, the cerebral metabolic rate is almost 15%, and the safe time for the hypothermic circulatory arrest without cerebral adjuvant is almost 30 minutes. So what are the pathogenesis that we want to avoid, pathogenesis of the brain injury that we want to avoid in hypothermic circulatory arrest? We have two types of brain injury during cerebral arrest, permanent and reversible or temporary. The permanent one, which is commonly referred to as stroke and manifests as focal neurological deficit, usually secondary to embolism of particulate. And the second type, which is the temporary, and it is reversible and it is diffuse, usually due to inadequate cerebral protection. The temporary is usually manifest as confusion, agitation, delirium, and the brain imaging usually negative in the temporary neurological dysfunction. And it is usually result in as a manifestation of global cerebral ischemia that result in necrotic or apoptotic neuronal cell death. So what are the risk factors for neuronal cell necrosis following hypothermic circulatory arrest? Inadequate level of hypothermia, presence of electrical activity during hypothermia, prolonged duration of circ-arrest, like more than 40 minutes without cerebral perfusion, and usually the apoptotic cell death begin within hours of reperfusion and continue as long as 72 hours after the circ-arrest. If it is temporary, it will resume to normal function, and if it is permanent, that means that the brain has ischemic insult. So now we are going into the main topic of our presentation, which is the deep hypothermic circulatory arrest. We have already talk about the cerebral metabolism, how the brain works, what does it need, what is the main source of the energy, and what happened if there is ischemia to the brain. So the main topic of our presentation is the hypothermic circulatory arrest. When we need to use hypothermic circulatory arrest, we have 4 indications, mainly for aortic arch surgery and cardiac surgery, like aortic dissection and arch aneurysm. And when we need a bloodless field, like thoracoabdominal aneurysm, renal tumor invading inferior vena cava, complex congenital cardiac surgery, pulmonary thromboendarterectomy and neurosurgery. Also, when there is when it's impossible to clamp the aorta, like porcelain aorta or distal ascending aortic aneurysm, and lastly, to control and repair massive hemorrhage, like in reduced sternotomy or repair of fractured thoracic aorta. So in these cases, we need a bloodless field, and we need to control the aorta, and we need to do the surgery with no blood in the body. That's why we need use of hypothermic circulatory arrest. So hypothermic circulatory arrest, as we said, is to stop the circulation in the body while maintaining cerebral perfusion. So what are the sequence for deep hypothermic circulatory arrest? It is cooling, starting bypass, cool the patient, stopping the bypass, do the procedure, and then rewarming. So first of all, after we start the bypass, by using the bypass, we go down with the patient core temperature, which is usually the nasopharyngeal, to the desired temperature we want, which is usually about 15 to 18 centigrade. During the warming, we have to keep in mind that the gradient, the temperature gradient between the venous return and the arterial inflow should not exceed 10 centigrade to prevent the formation of the gases emboli. And when using hypothermic circulatory alone, or in conjunction with the retrograde cerebral perfusion, then the cooling strategy will be based upon esophageal and nasopharyngeal temperature, as these two sites has been shown could be close approximately to the brain temperature. But when using antigrade cerebral perfusion with the circ arrest, bladder or rectal temperature are more important, as in the antigrade cerebral perfusion, the visceral organ protection is the primary goal of the hypothermia. So two important points while cooling the patient. You have to keep in mind that cooling for a minimum 30 minutes before stopping the bypass is required, and a goal of a nasopharyngeal temperature of 18 with a jugular venous saturation of oxygen more than 95. This will tell us that there is a minimum metabolism or consumption of the oxygen in the brain. This is the first point. The second point is electrocerebral science, of course. So these 2 points will ensure us that there is a minimal cerebral metabolism and oxygen consumption in the brain. If hypothermic circulatory alone is employed, then topical cooling by packing the head ice is advocated to minimize the upward drift of the intracranial pressure during the ischemic period. So we have some parameter to manage during the circ arrest, which is the hematocrit and the pH. So how to manage hematocrit during the circ arrest? First you need to know that as the temperature decreases, the metabolic rate decreases. So this will reduce the oxygen requirement of the tissue and will increase the blood viscosity and will increase the risk of sludging of the hematocrit if it's remain above 35. So during hypothermia, we need a lower level of hematocrit. So how do we manage that? As a fact, hematocrit is proportionally reduced to match the temperature in degree centigrade. So for example, if we lower the temperature to 20 degree, the hematocrit level should be maintained about 20. If we lower the temperature to 18, the hematocrit level should be about 18 during hypothermia. Of course, it diverges in the rewarming, and we will talk about that. The other
No voice, yeah, Dr. Rasha.
that is that the pH stat maintain the normal pH at hypothermia by adding CO2 to the blood during cooling. Why? Because hypothermia will make the blood alkalotic and hypocapnic. So to maintain a normal pH at hypothermia, we need to add CO2 to cool blood while cooling the blood. Adding this CO2, as we know that CO2 is a potent vasodilator, so it will cause a cerebral vasodilation, and this will eliminate the autoregulatory capacity of the cerebral microvasculature, and this will result in increase in the cerebral blood flow, as we said before. This and also the other effect of adding CO2 to the blood, it will drift the oxyhemoglobin dissociation curve to the right. That means that the hemoglobin affinity to oxygen will decrease, and it will increase the delivery of oxygen to tissue. Keep in mind that you are adding CO2, so while rewarming and you are adding CO2, the blood will become acidotic and hypercapnic when the blood temperature is rewarmed to 37. In contrast, the alpha stat maintain the normal acidemia in the blood at the normothermia, which is normal pH and normal temperature. And this will optimize the cellular activity because the autoregulation of the microvasculature of this brain will not be lost. So this will optimize the cellular enzyme activity and preserve the cerebral autoregulation. In the alpha stat strategy, we allow the pH to change as the blood temperature decrease. So we allow the blood to become more alkaline and more hypocapnic. And this will shift the oxyhemoglobin dissociation curve to the left, will increase the affinity of hemoglobin to oxygen and decrease the release of oxygen to the tissue. So the fraction of oxygen dissolved in the blood will represent the major source of oxygen to the tissue. So when to use alpha stat and when to use the pH stat. Alpha stat is more optimal in adult. Why? Because in adult we want to preserve the autoregulatory of the brain circulation in the hypothermia to adjust any area of stenosis and this proportion of disproportionate distribution of the flow. This can be maintained by the autoregulation of the blood. But in children, in children, global vasodilation is required, which is associated with the pH stat to augment blood flow during prolonged low flow state. So alpha stat is better in cooling. Alpha stat is better in adult and rewarming, and pH stat is better in children and cooling the patient. This is a table showing summary the difference between the pH stat and alpha stat. As we just said that the pH stat, it's a temperature corrected acid-base management, but in the alpha stat, it's a non-temperature corrected acid-base management. In the pH stat, we are adding CO2 to maintain the pH at a lower temperature, and in the alpha stat, we are allowing the pH to change while the temperature decreases. Cerebral perfusion regulation is lost in the pH stats because we are adding CO2, and this will increase the cerebral blood flow, allowing more uniform cooling, but this also will increase the microenvironment and the cerebral circulation. In contrast, in the alpha stats, cerebral perfusion pressure is maintained and the autoregulation is maintained, and continuous cerebral flow is maintained in the alpha stat. In the pH stat, as we said, the lower pH pressure will give us more acidotic cell. This may delay the cerebral metabolic recovery while rewarming, but also it will reduce the perfusion injury. But in the alpha stat, the protein and the enzyme function also all are preserved, and this will lead to better metabolic recovery during rewarming. The pH stat will lead to right drift of the hemoglobin dissociation curve, and the alpha stat will lead to left drift to hemoglobin oxygen dissociation curve. And as we say, the alpha stat is better in adult, and pH stat is better in children. Summary of the difference between the pH stat and alpha stat. So now we have already put the patient in hypothermic circulatory arrest. We say that.
Dr. Arata,
أيوة.
you brought that table from Oxford, the pH stat, alpha stat.
Yes.
Oh, okay, خلاص, thank you.
Okay. So now, just to summary up, we already started the patient on bypass. We cooled the patient to about 18 to 15 centigrade. We keep that cold hypothermia for about 30 minutes to ensure a minimal cerebral metabolism. And then after that, we clamp the arterial line and the circulating volume all drained into the venous reservoir, and the pump switch off. So then we start doing our surgery. If it is more than 30 minutes, we need adjuvant. If it is less than 30 minutes, hypothermic circulatory arrest alone is enough. After that, after completing the procedure, then we can start circulation at a very slow rate, like about 500 milliliters per minute in antigrade direction. And we keep a cold blood flow prior to rewarming, about like 10 to 15 minutes before rewarming. This will reduce the formation of the gases emboli. So cold perfusion has also been associated with improved cold reperfusion. Like before rewarming, we start 10 to 15 minutes of cold reperfusion, because it's showed that it's associated with improved cerebral perfusion and reduction in the cranial pressure and decrease the cerebral edema. In reperfusion or rewarming, we need a higher level of hematocrit delivered. In contrast to hypothermia, we said in hypothermia, we need a lower level of hematocrit level because the blood viscosity is increased during hypothermia. But in rewarming, we need a higher level of hematocrit level to increase the oxygen delivery to the tissue. Study shows that lower level of hematocrit limit about 20% associated with brain injury compared to hematocrit level about 30% and above. Also, we have to keep in mind that don't elevate the temperature more than 36.5, because cerebral hyperthermia results in worse neurobehavioral outcome and increase in neuronal cell injury compared to mild hypothermia. So what are the safe duration of hypothermic circulatory arrest? We already have been mentioned that in the previous slides, but I will repeat it now. Using hypothermia circulatory alone without adjunctive cerebral reperfusion represent the simplest and most convenient way for cerebral protection. But you can use circ arrest alone for only 30 minutes. If you need to extend the period more than 30 minutes, then adjunctive cerebral perfusion should be employed. What are the cerebral protection adjuvant we need with the circ arrest? We will talk in that later. This is the table I already showed you, that like on 15 degree temperature, the safe duration is about 31, and 10 degree, the safe duration about 45. More than 45 minutes will lead to ischemic brain injury. Now, if you find that yourself that you need more than 45 minutes time to complete your surgery, then you need to do a cerebral perfusion strategy. We have two strategies, retrograde cerebral perfusions and antigrade cerebral perfusion. Retrograde cerebral perfusion usually through the SVC, we cannulate the superior vena cava with almost 24 French cannula attached to the arterial line via a Y connectors and downstream to the arterial line clamp. And the flow usually about 250 to 400 ml per minute because it's a large vessels, but the perfusion pressure should be low because it's a venous vessels, so the perfusion pressure should be 25 to 40 mHg. How do you know that we are perfusing the brain successfully? We will have a dark deoxygenated blood return to the aortic arch. This will indicate a good cerebral oxygen uptake. This is the retrograde cerebral perfusion. Important to know the flow rate of the retrograde cerebral perfusion and the perfusion pressure, and how to know that you have maintained the cerebral perfusion. So in the selective antigrade cerebral perfusion, in contrast to the retrograde cerebral perfusion, the studies showed that the antigrade cerebral perfusion has superiority compared to retrograde in providing reliable cerebral perfusion. And this is done by transcranial Doppler measurement of the middle cerebral artery. And also showed that deep hypothermic circulatory arrest with retrograde cerebral perfusion or CIRC alone demonstrated significant drop in cerebral pH in contrast to selective antigrade cerebral perfusion. It's associated with improved neurological recovery, lower intracranial pressure, and less cerebral edema. So it's better than the retrograde. So what are the techniques for the selective antigrade cerebral perfusion? We have two techniques. Either we use bilateral selective antigrade cerebral perfusion or unilateral. The bilateral usually involves the cannulation of the left and right common carotid artery, or we put the cannula and the ostia of the innominate and left carotid artery via the open arch during the circle arrest. The other technique we have is the unilateral, which is the most commonly used via the right axillary artery. An 8 millimeter graft is sewn to the right axillary artery before the sternotomy, and we use this axillary artery as an arterial inflow line to initiate a bypass. At the time of the circ arrest, and we need to decrease the blood flow to 10 ml per kg per minute. If you remember, we said in the retrograde we have a large vessel, so the flow rate is about 250 to 400 milliliter per kg. But in the antigrade, we have a small artery, so the flow will be 10 milliliter per kg per minute, and the pressure is about 50 to 60 because it's in arterial line. We can do a left carotid occlusion to pressurize extracranial circulation and collateral system and minimize the steal. This antigrade cerebral perfusion enables blood flow via the right common carotid and right vertebral artery to perfuse the brain and the spinal cord. But one critique for this unilateral antigrade cerebral perfusion, that it provides insufficient cerebral blood flow to the left cerebral hemisphere because we are using the right side. However, all the study demonstrated that there is no difference in the cerebral blood flow between unilateral or bilateral cerebral protection with and without use of intact circulatory. So, any question until here? So we have already covered the circ arrest, how to do the circ arrest, and what is the parameter we need to measure, and what is the adjuvant for cerebral protection.
Doctora?
Yeah,
no, interesting, very nice details. I don't have a question. Just the main source you're using here is Lawrence?
Yes.
Yes, okay, thank you.
Okay, So for cerebral perfusion method for monitoring cerebral perfusion during circulatory arrest, we have, of course, the nasopharyngeal temperature. And as we said, the internal jugular venous saturation should be more than 95. This signifies that it's a minimal cerebral auto-extraction and minimal cerebral activity. Also, using of the EEG silence indicate minimal cerebral metabolism, but they say that it's not always a reliable marker. And of course, near infrared spectroscopy is a direct measurement of the autoconsumption in the brain. So other agents are used to minimize cerebral injury during circ arrest is the use of the ice pack around the head to ensure a uniform cooling, and pharmacological method, of course, like 100 milligram of this dexamethasone and 1 milligram of mannitols. Some people use thiamine, but it's often not used in large doses because it has a negative inotropic side effects. We already talked about Antigrade and Retrograde cerebral perfusion, and also we need normal glycemia because hyperglycemia can contribute to brain injury. So we have finished already the hypothermic circulatory arrest part with all its details. The last topic we want to talk about is the moderate hypothermia. The term moderate hypothermia has been introduced to us after introducing of the selective antigrade cerebral protection, because antigrade cerebral protection in use with the circ arrest has introduced us the term moderate hypothermia. Because the main concept of the circ arrest, or the primary purpose of the systemic hypothermia, is to provide protection to the visceral organ and the brain, like skeletal muscles, visceral organ, and the renals, and other organ in the body. As we said, the brain metabolic requirement is almost 7.5 times more than the normal visceral organ. So that's why we needed a very lower temperature to minimize the cerebral metabolism. But after using the antigrade cerebral perfusion, we don't need a very low degree of hypothermia, because the visceral organ, skeletal muscle, and the spinal cord metabolic rate are significantly less than the brain. So require reduced degree of hypothermia for optimal protection, and they are more tolerant of ischemia. Also, the induction of deep hypothermia is not a benign process. Deep hypothermia is associated with vascular and endothelial dysfunction, bleeding complication, and increased systemic inflammatory response. So, multiple studies result that the cardiopulmonary bypass after 180 minutes and deep hypothermia was a predictive risk factor for renal and liver dysfunction. So, for now, the moderate hypothermia for the lower body and using of cerebral selective antigrade cerebral protection currently represent the preferred circulation management strategy. It has a lower complication and a more convenient way for hypothermia. Last thing is the complication of the hypothermic circulatory arrest. Of course, the complication of the bypass, which is coagulopathy-related dysfunction, systemic inflammatory response, neurological injuries secondary to ischemia, particulate and gases embolism.
Doctora, how long we can go with moderate hypothermia with selective antigrade?
If you have a selective antigrade cerebral perfusion, you can go more above 1 hour maximum, maximum to 1 hour, because after that you will need to reperfuse the lower body.
So the ischemic time for other organs would be 1 hour?
Almost 1 hour.
Okay, thank you.
I don't know, Dr. Nasser, if you have any comment on that. Okay. So
mute.
Any other questions before I go to the questions? Alas? Okay.
دكتور ناصر comment but
الو رشا تسمع؟
ايوه. So Dr. Nasser, there was a question that how long we can stay on moderate hypothermia with the selective antigrade cerebral perfusion without perfusion of the lower body. I said approximately 1 hour. More than that, there will be ischemia. What do you think?
Yeah, we can't say 1 hour. We can go more than 1 hour. We can monitor the peripheral circulation, also the peripheral oxygenation nowadays. So we can go more than, it's not 60 minutes. There is no definite time for mild hypothermia or deep hypothermia but at least for brain, 1 hour will increase the mortality. With the peripheral tissue, in some study, even the kidney, there is no kidney injury with a prolonged circulatory arrest. In some study, you can go more than 1 hour.
Okay, any other question?
So yeah, Doctor, this was my question. Since we're perfusing the brain, and so we're not really worried about the brain, but the other organs, and sometimes with complications and bleeding, and especially with art surgeries, it can take time. And this question is, I believe it's important how long we can go with this technique, but I'm not sure if there's a definite,
Yeah, there is no definite time, but the most important thing is usually surgery should be as short as possible, as fast as possible. Short time, less complication. But if the surgery you need more than 1 hour and you protect the brain and you're monitoring for the kidney, actually we can monitor the kidney only with urine output. And sometimes with arrest also, there is no urine output. And in thin patient, we can monitor the oxygenation of the kidney. But if you need, you can go more than 1 hour.
Okay, thank you.
And some surgery, you can't stop and reperfuse. You can't stop your surgery and reperfuse the lower body. So you can go more than 1 hour.
But Dr. Nasser, if you do that, would that make the body at risk of reperfusion injury, like the heart?
Yeah. Also the same with the metabolic derangement, with reperfusion.
Okay, can we continue, or any other question?
Any other question?
Okay, so I will ask you now.
Yeah, ask.
Okay, so our first question is, each of the following statements regarding cerebral protection during aortic arch reconstruction is true, except nasopharyngeal temperature underestimate by 2 to 4 centigrade the brain temperature during deworming. pH stat with alpha stat management require a correction based on temperature. Retrograde cerebral perfusion should be avoided in longer, more complex cases. Transcranial Doppler ultrasonography can reliably identify cerebral malperfusion. This should be an easy question. Please, أي أحد يجاوب. I have already talked about all this in the presentation. No answer?
Is the last one the false statement?
Okay, any other option?
Second one, pH stat management.
Yeah.
Require.
Yeah, I agree. Second one, please.
Okay.
No, second one is correct. Second one.
Yeah, the second one is correct. I have already mentioned that the pH stat required correction based because we are adding CO2 in the pH strategy. So we are correcting the pH with the temperature. And the first one is also correct because the nasal temperature is underestimated by 2 to 4 centigrade during the warming. And the last one is also correct because I already said that the infrared spectroscopy is a significant tool to identify cerebral malperfusion. So retrograde cerebral perfusion should be avoided in longer. Of course, no, we need retrograde cerebral brain perfusion in longer complex cases to perfuse the brain. So this is the wrong one.
I guess the phrasing of the second option was a little bit confusing because it says pH stat management requires a correction based on temperature. It should be based on the pH level.
No, it's based.
No.
You know what's the difference between pH and alpha stat?
So pH. So based on the pH, we're trying to keep it at
based
a
on
normal
temperature.
Yeah, but we correct it. But we correct it based on the pH that we get. We add CO2, isn't it?
No. We correct the pH based on temperature.
No, pH stat, you are correcting the pH based on the temperature. So as long as you go down the temperature, you are correcting the pH stat. You are correcting the pH of the blood according to the temperature. Is it clear now?
Is it clear? Alpha stat and pH stat, is it clear for all of you?
I think I understand what you're saying, but I mean the pH will change because the temperature is changing. But yeah, because we're going with pH strategy, that's why we're gonna correct the pH by adding CO2. So we'll be actually
based on temperature. Based on temperature.
You are correcting the pH based on the temperature.
Yeah, normally الIPG machine it measure the sample at 37 regardless temperature of the patient. If we use this strategy, it means this is alpha stat. But if we put the temperature of the patient, the actual temperature, there will be a measured corrected measurement of pH and CO2. Say at 22, pH will be 7.5 or 7.6. So we will correct this pH based on temperature 20 by adding CO2. This is in pH stat.
I think I got what you're saying. I think I got it.
Okay.
Yeah, it's clear.
Other question regarding this scenario?
Russia, regarding the monitoring, this is Doppler. It's a good monitoring for cerebral perfusion during the circulatory arrest. And you mentioned the jugular saturation.
Yes.
Normally, we don't use it as a routine measurement. It's an invasive, and it maybe not affected by regional ischemia. So usually we don't use it in jugular. We use the NIRS. And NIRS is a regional oxygenation of the brain. And we can use for a brain, and we can use it also for the peripheral tissue and the cuff muscle, maybe. Sometimes we use it for cuff muscle as a monitor for the peripheral oxygenation. El Doppler, it's a good monitor. El EEG, it's complex. Sometimes need special technician to interpret. So usually we use a modified EEG اللي هو patient status index. We can use it. And we use a NIRS اللي هو near infrared spectroscopy to measure cerebral oxygenation, and we can use it also for peripheral oxygenation.
Dr. Nasser,
أيوة.
Do you mind if I just repeat my understanding of the pH stat and alpha stat and tell me if I understand it correctly?
Yeah, okay.
So what I understand is for the pH stat, like normally in hypothermia, the body will become alkalotic, the blood. So if you measure it at the same normal body temperature, the pH from the ABG machine will be alkalotic. So in order to correct it, you will add CO2. But if you correct it, it will show you it's normal and you will not change anything. While in the alpha stat, you will manage uncorrected pH. So it will be alkalotic and you will keep adding CO2 to maintain it at the normal level. By the end of the hypothermic period, the patient will be acidotic. Is that right? Because you were managing uncorrected pH.
Yeah, you are right in pH stat, but in alpha stat we don't use CO2. أنا هشرح لك الديفرنس إن هي the same machine. الماشين same والتكنيك same. normally الماشين السامبل heated to 37. ناخذ سامبل من البيشنت 20 ولا 22 heated to 37 and it measure pH and CO2. Gases normally with low temperature, it's dissolved in the blood. It's not decreased. The CO2 is not decreased. The total amount is the same, but it's dissolved. So if we measure CO2 at that temperature, it will give low CO2 and high pH. In this technique or this strategy, we add CO2 to correct. At the end, after reperfusion, we'll get acidotic blood with more CO2. Yes, you are right in this. At the rewarming and reperfusion, there will be more CO2 and we have to wash it out with breathing or with a bypass machine. But in pH stat, we measure gas at 37, regardless the patient temperature. And we
pH
manage...
or alpha stat, Doctor?
Alpha stat. Alpha stat, we ignore the corrected measurement at low temperature, and we take only الABG result. تلقى فيها two result. الأولى فوق at 37 اللي هو هذا we use it with alpha stat strategy. The lower reading تلقاه corrected at the temperature of the patient. الانبوت نحن نحطه في الماشين temperature 20 or 22 والماشين according to the formula and the special equation في السيستم نفسها تعمل correction وتعمل measurement للبي اتش والCO2. if you manage your acid base with the pH stat, you will add CO2 to correct the pH. لأن the pH will be high, alkalotic. So you will add. In fact, total amount of CO2 will increase. لأن with low temperature, it dissolved هو اللي increase, dissociated من hemoglobin ويبدأ بس dissolved في البلد. فنحن في الالفا ستات strategy we ignore this alkalosis at low temperature and low CO2 and we manage at 37. We don't add CO2.
واضح يا دكتور، شكرا.
واضحة؟
إيه
للجميع.
Yes, thank you.
So next question.
all study Russia show no difference يعني في outcome between alpha stat والbeta stat. There's some benefit during the cooling. They use the pH stat والpediatric في children. They use the pH stat.
Okay. So the other question is, a 36-year-old man with a Marfan syndrome underwent a hemi-arch replacement under deep hypothermic circulatory arrest. In the immediate post-operative period, mediastinal drain output is high and the platelet count is low. Elements contributing to thrombocytopenia include each of the following except. Now this is a question to refresh your brain about the previous lecture with Dr. Rawan. It's not mainly about my lecture, so what do you think? Binding of platelets via GP receptors to interior surface of the cardiopulmonary bypass circuit, binding of thrombin to thrombodulin and resultant protein C activation, hypothermia leading to low kinin level, platelet protease activated receptor 1 mediated platelet activation, post-operative reinfusion of shed blood. All of these are contribute to thrombocytopenia except one.
Maybe post-op pre-infusion of shed blood.
Okay, any other option? Okay, so the answer is hypothermia leading to low kinin levels because as you all know, there is a 5-system activation during the bypass. One of them is the contact system, and the contact system lead to high level of kinin that will cause thrombocytopenia, not a low kinin levels. And the other 3 options all can cause thrombocytopenia as it's a result of the bypass circuit. And thank you. Any questions?
Thank you, Rasha, for this very nice presentation. Any questions?
Thank you, Dr. Rasha. Excellent presentation details.
Thank you, Dr. Rasha. Thank you, Dr. Nasser, for joining us today.
Thank you so much, all of you. It's my pleasure. Any question?
No one
What's your preferred strategy, Dr., in your practice for alpha stat and pH stat?
We're using only alpha stat. Uncorrected acid-base balance.
For both adult and pediatrics, Dr. Nasser?
Both in adult and pediatric. Actually, my experience more in adult, but the same in our center, either in Germany or here, we use only alpha stat.
Well, what I've seen in King Faisal here is the same alpha stat. I asked a few times for the anesthesia, but what I've seen is all mostly alpha stat. I don't know if the other resident have seen something else.
I don't know if anyone has experience with the pH stat. هو actually هي الديبيت هذه من سنين دائما الالفا ستات والبيتا ستات بس يعني no superior strategy على الأذر يعني بس في some study they show some benefit في البيدياتريك وال during السيفير الديب hypothermia only.
And it somehow makes sense if I think about it. We hear a story about people having accidents in areas where it's very cold and icy, and when they get them, they rewarm the bodies, and you cannot announce death until you reach the normal temperature. And some of them regain normal brain function and normal, and without even and the normal body will not be adding that.
No one will add CO2 for him, yeah. Because the CO2 is only dissolved, but the total amount are the same. It doesn't change. يعني total amount of CO2 is the same. but with low temperature, the oxygen and CO2 dissolved more in the blood.
Yeah.
Dr. Nasser, my question is, when we are at the rewarming phase, maybe Doctora said that, but I did not pay attention. What is the optimum rate for rewarming, like to prevent gas embolization or bubble forming in the blood?
Mentioned I think by Dr. Rasha هي الريت يعني 1.5 per minute, don't exceed the 0.5 per minute. أو
almost 500 milliliter per kg. Almost 500, I have mentioned. It's not written in the slides, but I have mentioned it's 500 milliliter per kg.
No, the temperature, Rasha.
It's called rewarming. Temperature ولا الفلو?
Temperature. الفلو in the 10 ml per kg. This is for selective perfusion, but temperature during rewarming 0.5 difference to prevent gas embolization, difference between arterial and venous, not more than 10. Should be not more than 10 degrees. There is a two temperature probe measuring the temperature at inlet and outlet, venous and arterial. And you have to keep the temperature difference not more than 10. And also you keep temperature of the cooler and the cooler heater machine and the blood temperature also not more than 10.
And is that the only strategy to prevent bubble forming, or is there other things that we can do?
This is the only one. You have to be slow in rewarming. Fast rewarming, gas embolization, and the brain will be, because you are injecting hot blood through the aortic cannula, so you will go higher with the brain, which is very sensitive to hyperthermia. And this is more than 37 or 37.5 is associated with brain injury. This is so it's very dangerous. You have to keep it slow and slow. The rewarming after deep hypothermic circulatory arrest may reach up to 90 minutes.
Also, Dr. Nasser, what I know is that perfusionists cannot exceed a certain number. The machine will alarm. It will not allow the rewarming rate.
Yeah, they can adjust the alarm. You have to monitor them also. They can adjust the alarm and they can go faster. Some perfusionists, I had experience with some perfusionists, they like to rewarm fast and they want to go home early. You have to stop them and rewarm slowly. This is a very, very important. And as Rasha mentioned, you have to start with the cold reperfusion first and then start rewarming slowly. Keep the difference not more than 10 between the arterial and inlet and outlet. We have temperature, we have to monitor inlet and outlet. This is a temperature probe in the bypass machine. And in the patient, we have two temperature probe, in the nasopharyngeal temperature and bladder temperature. We have to keep the temperature between nasopharyngeal and bladder also not more than 4 or 5. Don't go higher, the difference. You have to go very slow.
Dr. Nasser, one last question regarding after the circulatory arrest. I would guess that it would be some form of brain inflammation and some brain edema. Is it expected that the patient will have like fixed dilated pupils for some time after the procedure, or is that always abnormal?
Mostly abnormal. If the fixed dilated, and mostly abnormal. I don't know if you've seen someone with the fixed dilated after rewarming.
Yes, and my question comes because I attended the case of aortic dissection where we had to do circulatory arrest. After the OR and ICU, we noticed that he had the fixed dilated pupils. But the patient, the second day, improved. Judging by the behavior of the doctors around me, it seemed like it's expected. Unfortunately, I did not ask. I should have, but that's why I'm asking.
No, I don't think so. And regain his consciousness, the patient was full functioning?
Yes, actually, I saw him in the clinic after.
Another explanation could be just a sluggish pupils, very
reaction,
sluggish.
Maybe, yes.
Yeah,
Maybe
very low reaction.
Yeah, I agree. I don't think it's fixed dilated, Faisal.
Fixed dilated, I don't think so, no.
Yes, Dr. Farid, he was on some inotropes. I'm not sure if he was on epinephrine.
Yeah, maybe from inotrope.
Dr. Farid, we were discussing earlier about the pH stat, and what I've noticed that mostly alpha stat, even pediatric, what I've seen cases. I don't know if you have, if you use pH stat in some of your circ arrest cases. We have thoughts on that.
So different centers use different techniques, and just like you have heard earlier, like there's most of the time there's not a big difference between the two. We did at one time have major problems with our brain protection issues, and we had like an incidence of 3 to 4% of brain insults after surgery. So that prompted us to review our procedures, including the perfusion. I'm going to ask you one question, Hudayb. Do you know if our perfusionists use CO2 on pump?
I've asked before, and no, alpha stat.
Okay, well, whom did you ask, the anesthesia or the perfusionist?
Both. It was anesthesia. I asked two different anesthesia, and I asked one of the perfusionists, and he said no.
I would ask you to review the situation again, and don't just ask about the use of CO2, and go to the lab, the mini lab that we have on the back for pH measurements, and ask him how they measure the pH of that blood gas. Do they correct for the hypothermia or not? And you'll probably find a different answer. But anyway, the bottom line is
Dr. Farid, usually to the measurement, usually we correct with the temperature.
Yes.
Measurement.
So our team have agreed on certain procedures. I'm not going to reveal the answer to Dr. Hudayb. I want to go and find out exactly how is it done.
Okay.
There are two issues. One of them is the pump technique procedures, and what they do if they use CO2. And the second question is to go to the lab and see how they manage with the specimen. It's a very good teaching session, I would say. And I advise all of you guys, anytime you send anything to the lab, one day in those 7 years, just go and see what happens with that specimen, how they handle it, being a pH, being a sample, being a specimen that you send, a pathological specimen. All this is a good teaching. We don't have pathology as part of your rotations, but it's a very good thing to do, is to go one day in the lab and see how they handle your specimens. Anyway,
Yeah, agree.
By the way, thank you very much, Dr. Nasser, for
You're
attending
welcome.
and helping us with this session. It was really a pleasure.
I did nothing.
Your
Yeah,
comments
my
and
pleasure too.
Again, to answer Dr. Hudaib, there are different centers use different techniques. It's not a big deal as long as you have good results. And particular issues comes like Dr. Nasser have mentioned earlier in the pediatric group as well as in the cooling phase of those patients. Okay, good luck.
Thank you.
Thank you, Dr. Nasser.
Thank you. Yeah, good luck. Thank you, Rasha, for inviting me. Well done.
شكرا دكتور.
Yeah, Assalamu alaikum.